Good morning, everyone. A couple of things to discuss here. I'm going to share my screen. There we go. Look at that. Fantastic. First of all, not going to go into tremendous detail about where we are from an epidemiology standpoint. I think everybody recognizes the dire circumstances we're in. I will point out that we have achieved the dubious status of 10th world ranking in cases over the last 2 weeks. If we were a country, this was in the New York Times this morning. So we're, I think, the state with the 7th highest disease activity over the last 2 weeks, and only 3 countries in the world over that 2-week period have had higher disease incidence than we have. The second thing I think is good to talk about is there's been a lot of vaccine news that's come out in the last couple of weeks, particularly in the last week, which has been pretty active and probably good to catch everybody up on that. So as everybody remembers, the vaccine development process consists of preclinical work followed by 3 phases of clinical trials, phase 3 being large trials that demonstrate efficacy in addition to getting additional safety data. The 2 leading vaccine candidates in the US arsenal, so to speak, for which we have contracts for manufacture and distribution are the Pfizer BioNTech vaccine and Moderna, as people have heard, and both came out with clinical trial data from the preliminary analysis in the past week and a half, and both with very good news. Pfizer initially announced early last week, I think, their milestone of preliminary analysis showing 90% efficacy. They since revised that yesterday when the CEO came out and announced that further analysis of data they had showed that the vaccine had 95% efficacy. 170 cases of COVID-19 encountered in their clinical trial, the vast majority of which, it was 163, were seen in the placebo group. Also encouraging was that of the 10 severe cases of COVID-19 that they saw in their clinical trial, all but 1 were seen in the placebo group. So there is great, I think, encouragement by the efficacy data there, again, early on after vaccination. And that was matched by encouraging news from Moderna, which earlier this week announced their preliminary analysis of essentially 95% efficacy as well. Additional news from Moderna is they've also updated their stability data and now feel that their vaccine has evidence of stability at refrigerator temperatures for up to a month. And so that obviously makes the supply chain distribution problem for the Moderna vaccine a lot easier. The Pfizer vaccine still requires ultra cold storage at -70. So the probable sequence of events, and I read a brief news report this morning, so I think that Pfizer has actually already now submitted their EUA application, or that will be going in today. So those applications, I think both will go into the FDA within the next couple of weeks. The FDA has a meeting of their vaccine advisory committee December 8th through 10th, and the general consensus is that committee will review the data from both of these vaccines and will probably recommend that FDA provide EUA authorization, which in all likelihood would come very soon after that. And so we could start rolling out vaccines by mid-December. Now, right now, it appears that both companies together will have about 45 million doses of vaccine that could be rolled out initially, and that would be targeted at the first tier of prioritized recipients, which are generally going to be healthcare workers and first responders. Remember that both of these vaccines require 2 doses. And so if you have enough to vaccinate 22.5 million people, that's essentially every healthcare worker in the US and probably the vast, or at least a good portion of first responders. There are still many questions about both of these vaccines and vaccines coming down the pike, but particularly these. These are both RNA vaccines. It's a technology we've never used before in an approved vaccine. We don't know how long immunity will last, and we don't understand immunity very well for this coronavirus. And so while it's great that the vaccines had 95% efficacy 2 weeks after the second dose, we don't know if that immunity lasts 2 months or 2 years or 20 years. We really just don't know right now. So those are data that will continue to accumulate. We also have really almost no data on pediatric efficacy. The Pfizer vaccine had started to enroll adolescents, children over the age of 12, later in their clinical trial. I'm not sure how many of that age group they've actually enrolled now, but neither of these vaccines has enrolled anybody under the age of 12. And because this is a new technology, we really have no safety and efficacy data in kids for these vaccines. So it's very unlikely that kids would be prioritized to receive one of these vaccines in the near future until we get more safety data from clinical trials. And so it's probably going to be left to some of the other vaccines that are in the development pipeline to be able to cover kids, and those probably will not be ready to roll out until spring, but we'll see. Obviously, supply chain and logistics of distributing these vaccines is going to be a challenge, especially with the cold chain requirements, but even so, vaccinating 22 million people over the course of 6 weeks is not a small thing, especially when it's outside of the normal system. And then obviously there's going to be issues with ongoing safety monitoring. So just wanted to make sure we were caught up there. And the last thing I want to talk about today is we've been working with some partners from the University of Pittsburgh and Carnegie Mellon in Pittsburgh, and wanted to share a little bit of the data that they've generously provided for us, and really appreciate the effort they've put in here, starting to tailor some of their data to help us look at phenomena across the Midwest. And I don't know if Seema and her team are on, but we'll introduce them at the end if they are. But thanks, Seema, to you and everybody for helping with this. A couple of interesting things I think to point out in these data. They focused on Iowa because I think Iowa has some interesting examples of where different interventions have been introduced across counties, and allow us to explore a little bit how those different interventions have effect. So these are the counties shaded that they've investigated so far. You can see in Iowa, the median population for a county is just about 16,000. They've looked at an array of counties that are some smaller, some larger, and some kind of in medium. If you look at these graphs, here's a little bit of a guide of what we're going to be looking at. And the nice thing is in this PowerPoint, these links are actually hyperlinked if you have it in presenter mode, so you can go to the data page and actually play with them yourself. So I encourage everybody to do that. But you can see here, this is a case curve. These dots are individual days of cases per 50,000 people, normalized so that they can compare county to county and visualize consistently. The gray bar is the rolling average for 7 days. So that is the smoothed out average of where cases are. And all of these vertical lines are interventions, some of them being implemented and some of them being lifted, and you can see the color code there. You can click on these and you can scroll over them and find out what the interventions were, and then click on them to remove them from the graph to allow you to visualize more clearly. And then this bar here with K through 12 also tells you what school posture was like, at least for K through 12. So all of these things allow you to look at these relationships. And I won't hyperlink them because when I did before in presentation mode, it wigged out my computer. But again, you all can go online and play with these. I think what's interesting is to be able to start looking at differences in counties. This is in small counties where you can see interventions correlating with increases or relaxation of interventions potentially correlating with increases, and new restrictions correlating with diminishment of cases. Both of these counties, interestingly, have small colleges located within them, which may explain why even before K through 12 schools went back in, you start to see an increase in transmission. You can see the difference between Winneshiek County and Henry is that Winneshiek implemented a face mask policy or face covering, mandatory face covering there, as you can see, soon after their case counts went up and right about the time school went back in session, when Henry did not. Next is looking at larger counties with colleges. And again, you can see the very sharp increase in cases that was associated with those colleges going back in. Some of the interventions that were put in place immediately that controlled transmission, but then the recurrence of rising cases that occurred in October. Again, some in correlation with relaxation of some of the interventions that were put in response to colleges. Here's a list of all of the counties that they analyzed. And again, these hyperlinks are active, so you can go in here and take a look for yourself, and I would recommend you do so. Another part of the analysis is looking at the time lag between implementation or relaxation of these interventions and what happens to case counts over a 2 or 3 week period afterwards. So this line, the diagonal line in the center, means that the case count is the same today as it was 2 weeks in the past, or however long the time period is they're looking. If you're to the bottom right, that means that today's cases are lower than where they were when the intervention was implemented. So that's improvement. If you go top left, that's a worsening epidemic, which means cases today are worse than where they were before. And what you can see is with a 3-week lag, there's still a significant time delay in implementing interventions. And when you see actual effect, consistently across the counties that did so, the big effect that was seen is down here on the bottom right, which was bar closure and alcohol curfew. These were in the college towns that had large outbreaks. You can go through again and look at the difference between 2, 3, and 4 week lag. So this is the 3 week. I encourage you to link on these hyperlinks and look at the 3 or the 2 and 4 week times again. And also you can look for Story County here, which is, I believe, where Iowa State is. So good information that starts to give you the ability to kind of see trends and time delays associated with implementation of NPIs and the effect of those. I think Seema and the team are going to continue creating more of these. So Seema, if you and the team are on, thank you so much for working on this, and look forward to doing more analysis with you. So that's all I have. Thanks, Shelley.